Well, good morning or good afternoon, wherever you may be. I've been looking forward to doing this webinar for quite some time now, and as I've been preparing for it, I've been thinking about obviously the situation in Washington, D.C., the kind of tone and tenor that's there, and I really desire to approach this from an analyst perspective, not a judge. Try to be as objective and as fair-minded as possible. And so I hope that that's the spirit in which it's delivered, and I hope that it's a helpful webinar for all of you. And we're going to cover a lot of facts and frameworks, a lot of detailed information. But let's just first start with feelings, and this is something that I oftentimes ask people, kind of 3 polling questions. And here are the questions. How many of you are positive about prospective health policy changes under the Trump administration? How many of you are optimistic? How many of you are negative or pessimistic? And how many of you are kind of neutral? Wait and see. Let's see what happens. So here's some results that 2 different times I've done this with groups of people. End of February last year at a Health Connect Partners event in Miami, it's kind of split equally, 1/3, 1/3, 1/3, between positive, neutral, and negative. But at the end of August, the very end of August, at an OR Today live event in Reston, Virginia, only about 10% of the people were positive, half the people were clearly negative, and about 40% were neutral. So things had really changed, and that maybe reflects some of the things that have gone on in Washington, D.C. In the first 6-7 months of 2017. So as we delve into this topic, my encouragement to all of us would be to look at this through a societal lens, looking at what's best for the United States, our nation, and not just what's best for your state or what's best for your health system or your hospital, your department, or even your own job. But really think about it from a stewardship for the nation standpoint, a societal perspective. Shakespeare in The Tempest wrote that the past is prologue. So let's take a trip down memory lane to understand the context in which we, and I'd say the Trump administration, find ourselves. And this has to do with the Affordable Care Act, the background here. It's been 7 years and 10 months since the Affordable Care Act was implemented, signed into law. And it's the only piece of major social reform legislation that was not supported by a single vote from the minority or opposition party. I looked at the legislative history for the creation of Medicare and Medicaid in 1965, and quite a few Republicans actually voted for that amendment to the Social Security Act. It was not solely Democrats who supported that legislation. Of course, the last thing about the Affordable Care Act is that it's really complex. Many, many pages in itself, as well as over 450 sections, and then thousands upon thousands of pages of regulations because of the rulemaking process that's required to develop policies. It's had a bit of a rocky road, and I'm going to cover 4 different areas in which the Affordable Care Act has had some challenges. First one had to do with its constitutionality of the individual mandate. You may remember that very dramatic period of time. That was June 28th, a Thursday, 2012. It was high drama. It seemed like the entire nation was interested in what was going on. And it was a tight, close vote, 5-4. John Roberts, the Supreme Court Justice, ruling in favor of the constitutionality of the individual mandate. So that was one challenge, a legal challenge. The second thing is that there have been legislative challenges over the entire Obama administration post-passage of the Affordable Care Act. The number one campaign promise in 2016 of all the Republican candidates was, for president, was to repeal and replace the Affordable Care Act. And if you think about those 60 bills that were introduced in Congress, it's basically a bill every 5 weeks after the law was passed. So imagine if you were President Obama, how that felt, that here we go again, another 5 weeks have passed, another bill is being introduced to repeal his signature piece of legislation. The third aspect of a rocky road is that Medicaid expansion was checkered. It was not consistent. 19 states have chosen not to expand Medicaid, but 31 states have, and the District of Columbia has as well. But that's been pretty stable for the last couple of years. And the last, but certainly not least, the health insurance marketplaces. These used to be called the exchanges, but they're really the health insurance marketplaces. They've had some challenges. The pool of people is more risky than people had expected, and 80 health plans left in 2016, and Aetna and some other national health plans, insurers, are completely out of the exchanges, and there's probably expectation that they'll be fully out within the next year or so. So what were the high-level goals of the Affordable Care Act? Because we still have those goals, regardless of whether you have the ACA enacted and in place or repeal it in any way, shape, or form. There were three goals, and they're still very solid and valid today. The first one was to increase access or coverage. In 2009, it's an astounding number here, 50 million Americans, which is almost 1/6 of the population, were without health care coverage. Let me say that again, 50 million Americans, almost 1/6 of the population, were without health care coverage. And you know what the unemployment rate was in 2009? In 2009, October was a peak, 10% unemployment. We're sitting at unemployment of about 4.1% right now, so it's about 2.5 times the rate of unemployment is what we had in October of 2009. Very different times, really challenging situation. The second goal was to slow the growth of healthcare spending, or as they said, to bend the cost curve. As we know, we spend a lot of money in healthcare, and according to CMS, Centers for Medicare and Medicaid Services, in 2017, we spent $3.5 trillion on healthcare, $3.5 trillion. That works out mathematically to $11,000 for every person per year, $11,000 per person per year. And that's a lot in terms of our economy. 18% of our GDP, it's way more than many other countries, and that we expect that percentage to grow to 20% of GDP by 2026, from 18% up to 20% of our GDP. Now, the third goal was to improve quality, and that had to do with reducing medical errors and reducing readmissions, etc. So which of these three goals was most emphasized during last year's lengthy debate on repealing and replacing the ACA? That was basically from January through July. What were which of those three goals was most emphasized? Well, it was access by a landslide. There's a lot of concern about the impact of a pullback of the Medicaid expansion and what we're going to do with the health insurance marketplaces, the individual insurance marketplaces. It was about access. Cost was rarely mentioned. It was not part of the discussion. And quality was, I don't think, mentioned at all. I don't recall it ever being brought up during the first 7 months of 2017. Now, I want to share with you a framework for understanding the political battleground in the District of Columbia. The first thing is messaging, and this is the politicking that we're kind of used to. Traditionally, it'd be like press conferences and press releases and interviews. But of course, with the Trump administration, tweeting is the primary way in which communication is taking place from the executive branch. There are press conferences, of course. There are some interviews and some press releases, but really, the media cycle is we respond to tweeting. The second part of it, though, is the actual policy making, and this is my encouragement to all of us, is to really focus in on this. This is the real game, the real legislative process here, the practical implications and what matters most. The lobbying work that goes on behind the scenes, the committee work, and we'll talk about some committees in a moment here, the actual bills that are being proposed and rulemaking processes. That's what is effective policy making. That's really what will impact how the healthcare system will work. But there's a third party in this conflict, and that has to do with the media. And this has been a phenomenon, I think, since the rise of the cable news networks. The media used to be that there was journalistic independence and right down the middle. And ABC, NBC, and CBS would pride themselves on being good journalists and not being objective as much as possible. But the media today, and this is across all types of media, take stances or positions on issues. And it's clear that there is bias and advocacy going on, and it's become part of the fabric of our society, and certainly in Washington, D.C. So journalistic independence is no longer at the pinnacle of values, apparently. That doesn't mean that some people don't believe in it. It's just that the prevailing tide is one in which the media take positions, and they're not focused on journalistic independence. Now, of course, the goal of both parties, the Republicans and Democrats, is to claim the moral high ground. They want to be able to say that we're the good guys, so to speak. We're the guardian of your health. We have the best plan for health care. It makes the most sense. It'll take care of people. It'll be fair and equitable. It will be the best healthcare system. That's what they're shooting for. That's what they're gunning for in the discussion here. So in terms of the messaging and the policy making and the interaction with the media, it's the moral high ground that everyone is trying to get at, especially the political parties. So we talked about the ACA. What were the Republicans' specific promises and policy proposals? What were they promising to come in with when President Trump was inaugurated? In January 2017, I wrote a piece for HFM, Healthcare Financial Management, which is the monthly journal of the Healthcare Financial Management Association, or HFMA. That whole issue was, as you can see here, it was focused on the outlook for healthcare policy. What I did was some research and analysis, and here I'm going to show you a table. I reviewed in detail the 5 most substantive policy statements of the Republican Party and Donald Trump from 2016. I just tallied up manually the major policies that were mentioned in those documents. It's interesting that 11 of them, 11 policies or policy statements, appeared in at least 3 of the 5, 11. And 4 of them, as you can see with the red arrows here, appeared in all 5. They were common to all of them. Here they are. Generally, repeal and replace Obamacare, promote the use of health savings accounts, allow insurance to be sold across state lines, and encourage state management of Medicaid and Medicaid block grants. Those are the 4 that appeared in all 5 of the documents. I also noted one other thing. Complete alignment, 11 for 11, between Paul Ryan's A Better Way, which is the column there in the first column, and the Trump administration's health care plan, which is issued in November 2016. So between June 2016, Ryan plan, A Better Way, and November 2016, the Trump healthcare plan, 11 for 11, consistency between them. So those were the intents, right? Those are the goals of the Republicans and the Trump administration. So let's actually recap what happened in 2017. This might be painful for some people, but this is actually what happened. It started with a bang. First day of Donald Trump's administration, he was inaugurated on January 20th. His very first executive order was to minimize the economic burden of the ACA. One commentator called this a rhetorical scream, but a policy whisper. See, the president cannot just repeal legislation by himself. That's the legislative branch's role. So this was really a symbolic act. It was trying to show that he was going to keep his promise of repealing and replacing the Affordable Care Act. Now, what was going on in Congress? Well, 7 weeks later, the AHCA, the American Health Care Act of 2017, was released in the House by Paul Ryan and the congressional Republicans. It was released for discussion. Committees reviewed it. 2 days later, the powerful House Ways and Means Committee approved the AHCA, and the vote was along party lines. Obviously, the Republicans supporting it, the Democrats opposed to it. Following day, another very powerful House committee, the Energy and Commerce Committee, approved the AHCA also along party lines. And then with that, the Congressional Budget Office did what they call scoring the bill. They analyzed the bill for its impact on the budget deficit and other aspects of our economy. There was discussion and debate and various amendments to the AHCA, I think over 3 dozen. And almost 2 months later, the AHCA was passed by the House along party lines. You can see the vote there, 217 yay in support of it and 213 against it. So then the ball was in the court of the Senate. It was the Senate's turn to look at healthcare reform. They have a House bill now that's been passed for their consideration, but they aren't bound to take that bill and vote exactly on that. And indeed, the Senate chose to go a slightly different route. The different route was known as the BCRA, the Better Care Reconciliation Act of 2017. It was a different, more moderate bill because of the voting proportions and the dynamics, and the moderate Republicans that are in the Senate. CBO scored the bill on June 26th. This led to a revised version of the BCRA, and then on July 19th, the CBO scored the revision. So you can see the ebb and flow here of policy changes, revision of bills, and then the Congressional Budget Office scoring it, trying to keep up and analyze what's going on. On July 25th, there was a vote just to debate, basically repeal and replacement of the ACA. Not to actually repeal and replace it, but just can we debate it? This showed the challenges and the tenor of the discussion in Washington, D.C. Senator Rand Paul of Kentucky suggested a two-step approach. Repeal the ACA now, and figure out the replacement later. So kind of a Texas two-step, although he's from Kentucky. Repeal now and replace later. That was voted down, 45 to 55. And the reason probably was that some senators felt like, hey, what are we getting ourselves into if we vote for this? We have an undefined replacement plan. We don't even know what the replacement plan is. So a lot of people were uncomfortable with that. What are the assurances that it'll be to my liking? Some of the senators were asking that. So obviously, both the Democrats as well as a number of Republicans voted against that. Now, an extreme minimalist approach. If we can't do that, if we can't do the two-step approach, how about just a really skinny repeal? And July 28th, this minimalist approach, the skinny repeal, was put before the Senate, and it was rejected. It would repeal the individual mandate, repeal the employer mandate, and had some other provisions, 7 other provisions. But it didn't touch Medicaid. That was a very important point. It did not touch Medicaid, did not pull back the Medicaid expansion. The Senate voted it down, however, 51 to 49. And there's a picture here. That's actually John McCain, who's actually casting his vote against it. And most people say that he cast the pivotal vote because Susan Collins from Maine and Lisa Murkowski from Alaska had made their intentions known that they were going to vote against it. 2 Republican senators, and now 3 Republican senators voted against it. And therefore, there was not a 50-50 tie with Mike Pence, the vice president, as the tiebreaker. So that kind of put an end to, for the most part, we thought, to the attempts to repeal and replace the Affordable Care Act and to move on to other issues. And yet, something happened in December. In December, as we all know, Congress passed the Tax Cuts and Jobs Act, the TCJA. That was on December 20th. It was along largely party lines. Some Republicans didn't support it, but it was supported by most of them. And it was signed into law by President Trump on the 22nd of December. And it did a number of things. It reduced the corporate tax rate from 35 to 21%, effective in 2018. It repealed the individual mandate in 2019, so not this year, but next year. And it did not have any kind of mandatory, what's called PAYGO cut to Medicare. Congress waived that, which meant that even though it increased the deficit and the debt of the country by over $1 trillion, $1.4 trillion, they would not have any automatic cuts to Medicare. But a $1 trillion increase to the debt over a period of 10 years. So this leaves open the question how to decrease federal spending on healthcare because of the adverse impact on the nation's debt. That's the federal government's debt that has increased. So where does this all leave us? Well, some optimists say that we have the opportunity to move to bipartisanship. And Senator John McCain, who, as you all know, is suffering from cancer, is fighting cancer, there's high drama in the Senate when he pleaded for regular order, return to regular order, and compromise and bipartisanship. So he's a traditionalist, and he wants bipartisanship. So one of the questions is who could take the lead on a bipartisan approach to healthcare reform? Who would actually do that? And the most likely candidate is a committee. Earlier we talked about the House Ways and Means Committee and the Energy and Commerce Committee. Those are very powerful, influential committees. In the Senate, in this particular area of healthcare, it's called the HELP Committee, Health, Education, Labor, and Pensions Committee. That's the most powerful, influential committee comprised of very senior members of the Senate from both parties. So let's take a look at the people who are on it. There's actually 23 members on this committee, so it's quite significant. 12 of them are Republicans because the Republicans have the executive branch. 11 are Democrats. It's chaired by Lamar Alexander, a Republican from Tennessee. And the ranking member, in other words, the highest Democrat, is Patty Murray, who's a Democrat from Washington. And here's where these 23 members stand on the political spectrum, from left to right. Left meaning the most liberal, and right meaning the most conservative. And this is not my view. This is actually based on some the various websites that score and rank congressmen and senators and representatives based on their voting record. So this is where they fall out. So you can see a wide range of political views from left to right on the Senate Health Committee. So given the votes of the Senate and the Congressional Budget Office scores, we have three things that seem to be off the table in terms of the repeal and replacement of the Affordable Care Act and any kind of health reform going forward. Right now, I would say the Medicaid expansion pullback is off the table. This is based on some statements by some key pivotal GOP senators. Rob Portman, Shelley Capito. So Portman's from Ohio and Capito's from West Virginia. They're opposed to a Medicaid expansion pullback. Major changes to federal funding of Medicaid. There are some minor things that are being considered right now, requiring work. Certain states are going to require Medicaid recipients to work, some of them, and then defunding of Planned Parenthood. These items are, for the most part, largely off the table. So the challenge of compromise is interesting. You know, in boxing, you have boxers who are fighting, and then they'll fight, and then they go back to the corner. It's akin to a political caucus. Republicans and Democrats caucus and then go back to the corners, and they realize, hey, wait a minute, I'm not interested in compromising. I still believe in certain things. And I would just say that this is a fair statement. There are deep philosophical differences between and even within our political parties today. There's some people who say that we actually have 4 political parties, 2 different ones in the Republican Party and 2 in the Democrats. This makes compromise really difficult, if not impossible. Now, I'd like to highlight for you the kinds of philosophical differences there are. There are kind of 4 axes of debate and disagreement. First one has to do with the role and size of government. This is a very significant one that has been with us for decades and continues to be a philosophical underpinning of the debates. Second is individual rights and responsibilities. What are individuals responsible for? And third is federal versus state control. Republicans are generally more interested in states' rights versus federal control. And last, there's the public versus private sector. I want to share with you a brief story, true story about a dinner party that my wife and I hosted about 9 years ago. We had some guests who were staying with us. They were on holiday, as they say. They were Brits. They're from the UK. And as I think we all know, there's a National Health Service in the UK, and it's very different than the United States. We had another couple at our dinner party who are Americans. The American couple, as we were just starting our salads, and my wife was preparing the entrees in the kitchen, and I was in the dining room with our 4 guests. The woman in the American couple opened their mouth and said, "Oh, I read something the other day that I heard all the people in the UK get their surgeries done in India." And I was thinking, how this is going to be interesting. And this person is not in healthcare. And I was thinking how my British friend's going to respond to this. And I could see steam coming out of the ears of my friend Ian. And I thought, oh my goodness, we are not going to make it to dessert in this meal. We may have to cut this off. So I tried to redirect the conversation, talking about baseball or football or almost anything except healthcare. And honey, our entrees ready? You know, kind of let's talk about the food instead. And I was about ready to kick in the shin my friend, my American friend, for bringing this up. But anyway, cooler heads prevailed eventually, and Ian looked at me and said, so Ken, what was the state of the U.S. healthcare system at the end of World War II? And I said, well, there's a lot of experimentation going on. I know about Group Health Cooperative in Seattle and the Kaiser. There's a lot of work. The Blues plans were doing some interesting things, and yeah, a lot of innovation, I would just say. It wasn't a nationalized system. There's already a strong private sector. He said, What was the state of his next question, what was the state of the British healthcare system at the end of World War II? And I'm not an expert on that, but I think I knew generally what he was aiming for. So I said, flat on its back? And he goes, exactly. We had a handful of hospitals in the UK, mostly taking care of our troops, and we had about 25 million people. Then he said, Ken, one more question. If you were responsible for this healthcare system at the end of World War II, what approach would you have taken to get it organized? And I looked at him and I thought for himself, well, maybe I would have taken kind of a centralized kind of approach as well. This is exactly. And then he said, it's something that has always stuck with me, you in the United States talk about socialized medicine, but we view it as centralized. And it's not a negative thing from a British perspective. Now, the NHS does not have the entire healthcare system. It's about 80%. There's still private insurance there. But his point was well taken, that the historical context is very, very important. So this public versus private sector issue is one that differs between political parties in the United States, but also between countries. So one question is, what other legislation programs are not changing? What can you hang your hat on? And I just want to cover a few things here. So first of all, MACRA, which is the Medicare Access and Chip Reauthorization Act of 2015. It replaced what was called the SGR formula, Sustainable Growth Rate formula, which is very unpopular. In simple terms, what that was the inflation adjuster used to update the physician fee schedule, or PFS. MACRA was passed in 2015 and had widespread bipartisan support. It had 91% support in the House. It's passed 397 to 37. In the Senate, it had 92% support, 92 to 8 in the Senate. So both Republicans and Democrats supported MACRA. It promotes advanced alternative payment models, such as accountable care organizations. And I think this is something, even though there have been some rumblings about some changes to MACRA, in general, there is bipartisan support for MACRA. The second piece of legislation that is solid, you can hang your hat on, is the 21st Century Cures Act of 2016. This supports NIH and FDA funding. Most people are not against funding those key agencies. There's support for precision medicine, which is something most people are optimistic about, as well as efforts to address the opioid crisis, considered one of the top issues of concern by politicians of both stripes. Also, it had broad bipartisan support. It passed the House with 94% support, 392 to 26, and 95% of the Senate, 94 to 5 vote in the Senate. So that is a very solid piece of legislation. Again, some rumblings about some modifications to it, but in general, bipartisan support. And the third thing I want to mention was Medicare Advantage. It's long been supported by the GOP. It's a very popular program, increasingly popular program. There are 20.4 million enrollees in Medicare Advantage this year. And that's according to CMS. And that is 34% of Medicare beneficiaries. That's up significantly over the last 10 to 15 years. 68% of those enrollees are in 4- or 5-star programs, the Medicare Advantage STARS program. So that means that they're shopping around, the public is shopping around, and quality matters. They're choosing the higher rated Medicare Advantage plans. So what are some other areas of common ground between Democrats and Republicans? I think there are short-term, medium-term, as well as long-term examples. And maybe we can build on that. So first of all, short-term. Shoring up the health insurance marketplaces. We've got to do something with them. Democrats care a lot about this, as do a number of moderate Republicans. President Trump has told the Senate Help Committee Chair Lamar Alexander that he supports the Alexander-Murray Stabilization Bill. And so that's a bipartisan effort. So there's some optimism there could be something done to shore up these health insurance marketplaces, at least for the short term. Second area is to strengthen our response to the opioid crisis. I mentioned earlier Senators Rob Portman and Shelley Moore Capito from Ohio and West Virginia, respectively. Over 2 million Americans have a substance abuse disorder, and there are 100 deaths per day, 33,000 deaths in 2015. We project increases in the number of deaths to be 500,000 people in the next 10 years due to the opioid crisis. It's very expensive for our nation. We spent over $500 billion, $504 billion specifically, for our economy in 2015 to deal with the opioid crisis. So it's a big issue, and there's bipartisan concern about it. Another area has to do with the long-term bending the cost curve. And so ACOs actually came out of the George W. Bush administration, so it's not a Democrat idea. Although the Democrats support it, it's something that came out of George W. Bush's administration. Republicans support it in principle. Values-based care, the Affordable Care Act had 5 delivery reforms. Not all of these have fared as well as others, but in general, this is the path forward, according to people like Zeke Emanuel. There's a quote from him here. It's saying basically we've got to figure out alternative payment models tying reimbursement to quality and cost objectives. Then we have the Tax Cuts and Jobs Act I mentioned earlier. It's going to increase the federal debt by 1.4 to 1.5 trillion over the next 10 years. And in favor of the bill or the law is the fact that there'll be economic growth. $1 trillion increase, the net will be $1 trillion increase to the federal debt. So that will put pressure to reduce spending on healthcare going forward. And that's exactly what Paul Ryan has recently said. He said this in December. Frankly, it's the healthcare entitlements that are the big drivers of our debt. That's really where the problem lies, fiscally speaking. And so his concern is one that is appropriate, I think, is spot on. So what that means is we're going to need to target cost. We're going to need to target cost and look at the $1.2 trillion plus that's spent by the federal government each year on healthcare. Now, it's interesting that we have to be careful that, and we have those 3 goals of right coverage or access, lower cost, and quality. The interesting thing about it is if you simply increase coverage, that doesn't necessarily reduce cost. Sometimes it can go the other way. And I'm going to give you 2 empirical examples of this. First of all is Oregon. Oregon has probably the best randomized controlled study on this topic. They provided insurance to poor people, about 25,000 people in 2008, who did not have Medicaid coverage the year before. It resulted in a 40% increase in emergency department visits in the first 15 months. And then another study was done, and it showed even after 2 years, it still had this high rate of use of ED visits. What that showed was that old habits are hard to break. So that was very disappointing because costs went up for this cohort in Oregon. The second example is from my state, California. It has the largest Medicaid population in the United States. I was just telling someone about this yesterday. Staggering. We have about 38 million people in the state of California. 14 million of those people, about 40% of our population, are on Medicaid. It's a staggering number, and it's grown significantly, as you can see here, from 8 to 14 million as a result of the Medicaid expansion. Put that in context. That's 20% of the U.S. Medicaid population. 1 out of every 5 people on Medicaid live in the state of California. So what happened there was similar to what happened in Oregon. We provide insurance coverage through Medicaid, a 44% increase to the emergency department visits, and that was over a 2-year period of time. So that's a real challenge and something we need to bear in mind. Now, one of the things that's interesting is that natural disasters and tragedies bring our nation together. Think about Hurricane Katrina or the fires in California, the recent fires, earthquakes, things like that. But perhaps the biggest long-term driver of increased healthcare costs has to do with something about our society. It has to do with the number of Americans who are overweight and obese. And this is like a big tragedy, natural disaster. There's a looming natural disaster, and that is independent of the nature of our healthcare system. Regardless of how we pay for it, how we're organizing healthcare, we have this problem of our inputs in terms of the people and their condition. 40% of U.S. adults are obese. That's more than double what it was in the late 1970s. That's a staggering realization. Another 26% are overweight, and many of those are headed to becoming obese. Unfortunately, our children and adolescents are increasingly obese as well. And this is nearly triple. 17% of them are obese today. That's nearly triple what it was in the late 70s. It was about 6.9% at that time. And about a third of the children and adolescents are obese or overweight. Of course, we know that when you're obese, it can lead to all kinds of issues, health issues, cardiovascular disease, diabetes, and CKD. And look at the cost here and the magnitude of it. 29 million Americans are diabetic. 86 million are pre-diabetic. The massive amount of cost associated with that. That's $322 billion per year, just related to diabetes and pre-diabetes. That's about 9% of our total U.S. healthcare costs. Just that one disease. Staggering. Now, kind of depressed when you hear that and you think, oh my gosh, what can we do? Well, sometimes you can feel better about yourself when you realize other countries have it worse. And so I'm going to share with you an example of China. If you think we have it bad, consider China and the issues they have. So there's a research that's been done that basically says, hey, if you get exposed to air pollution at 10 to 12 micrograms per cubic meter, it's going to increase your risk of death significantly. 10 to 12, right? Guess what? The average concentration across all of China's geographic regions, there's over 30 of them, was 60.6 micrograms per cubic meter. So it's about 5 to 6 times the warning level, the danger level. And big cities are really bad, worse. Beijing is over 90. It averages over 90, and Shanghai over 50. These are actual pictures from those cities. Well, if the smog won't get you, how about smoking? Well, that's a big problem, and most of you know that there's a lot of smoking among Chinese men in particular. 68% of Chinese men smoke, and they smoke an average of 14.6 cigarettes per day. Very high. And, of course, we know smoking is really bad. Here's some of the warnings that we've seen over the years in the United States. First one is what I would say the direct approach. Smoking is bad for you at the very top there, right? It causes lung cancer, etc. Second one is more of an appeal to your, this is for pregnant women, care for your unborn baby, right, or care for your children. Smoking by pregnant women may result in fetal injury, premature birth, etc. And the last one, let's make it a positive. If you quit smoking, it's going to reduce your risk to your health, so it's a good thing. Quit smoking. Different approaches by the Surgeon General to get people to stop smoking. We also know, of course, that smoking causes all kinds of issues. All these health issues here, coronary heart disease, all the way to diabetes complications. So one interesting thing to put this in context is that low-level air pollution accounts for 6% of mortality and 3.3 million premature deaths per year globally. 6% of mortality and 3.3 million premature deaths per year. So the healthcare system in China, we have to deal with obesity and overweight Americans. They have to deal with air pollution and smoking. So you can imagine what the Chinese healthcare system is going to have to deal with in the next 5, 10, 15, 20 years. So one question you might be asking is, well, what do we do, and what do we really want if you're in a hospital, working in a hospital today? So this is what the hospital systems really want, and the hospital associations. They want 4 things. First of all, they want to stop increases to uncompensated care, basically. Bad debt and charity care hurt the income statements of hospitals. And so any increase to the uninsured population is something that the hospitals don't want. They want to prevent that. Second thing is they want to repeal the ACA hospital reimbursement cuts. Now, most people don't know this, but the ACA from 2010 to 2019 took away $113 billion in reimbursements from the hospitals through these 2 different programs, the negative market basket revisions and productivity adjustments. Basically what they did was they reduced the inflation adjuster for what's called the inpatient prospective payment systems. And as a result, hospitals got less money than they would have otherwise, $113 billion. Hospitals would love the ACA to be fully repealed in this aspect or in this regard. The third thing is they want to improve the 5 healthcare delivery forms that I mentioned earlier of the Affordable Care Act and make them more financially attractive or repeal some of them. Some of them are not as effective. There have been concerns voiced by hospitals. But some of them, hospitals and health systems definitely want to continue to pursue. But some sort of improvement in terms of making them more attractive and maybe easier to comply with. And then fourth and finally, the really interesting thing is that the hospitals are losing money on inpatient drug spending. And the Medicare's model or system for reimbursement doesn't keep pace with the rising drug prices. So a revision of that model, improvement of that model would help. There's a flawed reimbursement methodology of Medicare that needs to be changed, and hospitals, in particular the American Hospital Association, the Federation of American Hospitals, have lobbied for an update and improvement, revision to that model so that hospitals don't lose money on inpatient drugs. So to wrap things up, some conclusions, just 3 pieces of advice. First of all, especially with this administration and the difficulty in pulling together bipartisan legislation, we have to prepare for a period of uncertainty. Things are not all tacked down and perfect and clear. Secondly, we have to embrace value-based care because that is the path forward. Given the $1 trillion increase to the nation's debt, even after accommodation for economic growth, there's even more pressure to reduce federal spending. And as we saw from House Speaker Paul Ryan, the entitlement programs, and specifically health care, are going to be areas of great scrutiny and probably some downward pressure. So value-based care is important for the nation, and we're going to have to move in that direction, especially ACOs. There's about over 1,000 ACOs in the United States today. About 600 of those are Medicare, and the remainder, the vast majority, are commercial. And then last, no matter the payment model, no matter how we're organized, analytics, machine learning, and artificial intelligence across the care continuum are going to be really critical. This is the age of analytics. The power of computing is with us, and the importance and value of insight to reduce cost and improve quality is really something that's going to be the watchword for hospitals and health systems going forward. So that's my advice. And with that, I want to open it up, my contact information here. I want to open it up to Q&A.
Okay, thanks very much, Ken. Yes, we've had a few questions come in. One is, I've heard that the recently passed tax reform law repeals the individual mandate and will therefore result in 20 million Americans not having health insurance coverage. Is that true? And what is the Republican or Trump administration response to that concern?
Yeah, it's a good question. It's one actually I've been asked by a friend of mine who's works for a big financial institution. So the 20 million figure is the figure that was cited regarding a number of the broader ACA repeal and replace bills proposed last year. So remember in my presentation we talked about the Congressional Budget Office scoring the AHCA and the BCRA, both the House and the Senate bills. And that was the 20 million is associated with that. But that's the overall broad repeal and replace bills, not just the repeal and replacement, or repeal rather, of the individual mandate. So it applies to a broader repeal and replace legislation, not just the repeal of the individual mandate. Interestingly, if you look at the Congressional Budget Office's analysis of the Tax Cuts and Jobs Act specifically, and I've read it, 13 million people that would otherwise have health insurance coverage would not because of the repeal of the individual mandate. But that number is projected for 2025 through 2027. It doesn't happen instantaneously in 2019, so it slowly grows. In 2019, the number is projected to be 4 million. So that's first point, is to not be so alarmed because it's actually a slow growth in that number. But the other thing that's really interesting, this was brought up by the New York Times. I was reading an article about this and an analysis. The 13 million is composed of 5 million people who would choose to not get coverage through the individual insurance market, 5 million people who for some reason would not enroll in Medicaid, which I scratch my head thinking, why would they not do that? They have every right and incentive to do so. And then 3 million who would pass up employer-sponsored insurance. Again, that's a benefit that's highly valued by our workforce. So I don't understand why they would not do that. So the bottom line is I question the validity of the latter two categories. I certainly understand that maybe the healthy young individuals might not get insurance and just kind of take their chances and pay as they go. But I do think that the other two, about the people who there is no Medicaid pullback in the Tax Cuts and Jobs Act, and the employer-sponsored insurance is highly valued by almost all Americans, I think. So in terms of the second question, the Republicans would contend, in addition to maybe those points, that the economic benefits of lower taxes for lower income and middle income Americans, especially in the second lowest income tax bracket, with a drop in the tax rate from 15 to 12%, which is quite significant, could help boost enrollment in health plans. In other words, people who are relatively poor, lower middle class, lower class, would actually get more income, and therefore they would have more purchasing power when it comes to health insurance plans. So I think that's kind of their response. One last point on this is that I want to talk about the middle class. There are a lot of debates and disagreements actually about what is the middle class, how is it defined, and it's hilarious when you look at the literature on this. There's a lot of different definitions, and you'd be surprised to see how wide the range of interpretation is of that term.
Okay, that's great. And the next question is, what do you feel are the most likely areas of common ground between the Democrats and the Republicans on Capitol Hill?
Yeah, that's a good question. I think the thing that I mentioned in the presentation that covers it, I think there is bipartisan concern, though there's some disagreement regarding solutions regarding the health insurance marketplaces. It's a little bit like a Band-Aid situation here, but there's certainly concern by Democrats and at least a few Republicans in the Senate in particular, about the health insurance marketplaces. So I think there's a sense of we have to do something about this. Certainly responding to the opioid crisis, I think that's on both sides of the aisle. And then the need to bend the healthcare cost curve ultimately through value-based care. Now, that being said, I think philosophically, value-based care is something that people will nod in agreement in general, again, both sides of the aisle. With the Democrats pushing more for mandatory programs and the Trump administration and the Republicans expressing an interest, a preference for voluntary programs. So that's a slight nuance, but a very important one. But in general, I think people realize we have to figure out how to reduce the cost of healthcare going forward.
Okay, and given the experiences of Oregon and California, which demonstrated, unfortunately, that providing health insurance coverage increased emergency department use, what can be done to prevent that?
Yeah, I kind of left you hanging there just telling you about the bad news of Oregon and California. So actually, it is tough to break old habits, as I mentioned, and especially with the Medicaid populations. From personal experience, I live here in Menlo Park, California, and unfortunately I've had to go with my family members at various times to the emergency department on a Friday night. And if you go there on a Friday night at 5 o'clock, let's say, you're going to find a lot of poor people actually with their kids who have runny noses and probably shouldn't be there but they're used to going there. And that's not being melodramatic. That's the way it is. And I think that's a story of many, many hospitals in the United States. Now, the interesting thing about it is that Colorado has done a really good job of innovating in this area. The Accountable Care Collaborative, or ACC of Colorado, the nation's largest Medicaid ACO, has been doing work in this area for at least 5 years now. And they have actually an amazing track record of actually reducing emergency department visits as a result of a variety of steps to engage with enrollees. They didn't just provide the coverage or maintain the coverage. They've done some very interesting things. So first of all, they assign enrollees to a specific primary care physician. If you are in Medicaid in this program, which is over 1 million people in their program, by the way, you will know who your primary care physician is, and they will know who you are. And so being known and connected to your primary care physician, knowing how to contact them and them being able to follow up with you is really critical. So that's the first thing, some matchmaking between the patient or enrollee and the primary care physician. The second thing is a lot of education about when to go to the ED and when to go to the other care settings. And so they'll oftentimes talk to the advice nurse or talk to their primary care physician, and they'll learn that, hey, there's some other options you have out there rather than going straight to the emergency department. And the third thing is that there's a lot of care coordination. If you keep your regular doctor appointments, your well-child visits, etc., then you don't need to press the panic button and go to the emergency department because you've gotten a clean bill of health, or you've gotten the information you need, you've gotten your checkup, you've gotten your prescriptions, you've gotten whatever you need in terms of health maintenance. And care coordinators, usually nurses on the phones, have really tightened up those linkages and eliminated some of the issues of transitions of care, gaps in care in particular, and basically reminding them about appointments, fielding advice nurse kinds of questions, and that has really reduced emergency department use in the state of Colorado. And so it's no silver bullet, but multiple ways of getting people to change. And so it's not just behavioral economics, it's actually just patient engagement and communication and being known, being connected to the healthcare system.